The internet is a great source of information about all kinds of problems, including multiple sclerosis. However, sometimes it's not always your friend, and you may run into myths and misconceptions about multiple sclerosis. June Halper and David Jones will discuss some of what these myths and misconceptions are and how you can avoid falling into the trap of responding to those.
Hi, my name is June Halper. I'm a nurse practitioner. I've specialized in MS for many years. Hi, David.
Hi, I'm David Jones. I'm a neurologist at the University of Virginia, and I specialize in the care of people with multiple sclerosis.
Yeah, so it's great to get together.
It is great to get together.
Yeah, I guess, one of the things I'd like to talk about today is some of the challenges that we're facing in the nursing profession, the myths that we are dealing with and the misperceptions. So I was wondering, are you finding the same thing in your patients where people come in and before they even talk about treatment, how long do I have before I can't walk anymore or I have to start using a wheelchair?
I do find that it's a common question. I think the uncertainties of this disease are challenging for people. I think that many people go on the internet, sometimes on sites that may not be accurate, or they glean information from friends. And I think one of the biggest challenges is that before 1993, we had no disease-modifying therapies.
Right.
So if they know somebody that is well before that time, they may have accrued significant disability because there wasn't treatment and assume that their disease course will be the same.
Right, right. So their vision of MS is a downhill course. Yeah, because and I find the same thing in professionals. There are many docs and nurses and rehab specialists that have that same perception, because I don't know what your educational experience was, but I had all of 5 minutes of MS in my nursing, education, and even when I went on for my master's, it was hardly dealt with at all.
I would agree. That was my experience in medical school as well. And I can tell you many of our residents really don't have much exposure besides me to the rehabilitative aspects of the disease. And I think there still are a lot of myths among healthcare professionals that this is a disease that will slowly worsen no matter what.
Yeah, you're the head of the MS section at the Academy, and I know that group of docs are all involved in MS, but do you find that even among the older physicians, there's still that negative feeling, no matter what I do, even with the new DMTs, that it's a downhill slide?
I think there still is a perception that it is a downhill slide. And I think that part of that is because there's too much focus on the disease-modifying therapies and not as much focused on managing the symptoms. And I think certainly not as much focused on reinforcing that people with MS need to ensure that they own their disease and their disease does not own them.
Do you think that's one of the reasons why people with MS or many people with MS are going out onto the web and finding things about macrobiotic diets and all kinds of, when I first started in MS, it was snake venom. They were using cobra venom and then hyperbaric oxygen, or finally called HBO. But don't you still find that's happening where patients are exploring opportunities using what we call CAM or off-label kinds of treatments?
Absolutely. I had somebody ask me last week about a red hawk blood. Red-tailed hawk blood for MS. And I think in part the perception that many people with MS have is that disease-modifying therapies will make them feel better.
Right.
And I think most people that come in to see me are worried about feeling better today.
Right.
And many of the conversations I have is also, how do we prevent people from getting worse tomorrow?
Right.
So I think there's this perception they will get worse, but there's also a lack of understanding that the medicines we have for MS today can potentially prevent that, but they don't necessarily make people feel better today.
Do you find that some of the private practitioners, though, dealing with MS don't address the symptoms of the disease? They focus so much on their MRI and any new lesions, and are they taking their DMTs? And they don't address things like falls or bowel or bladder, or even mostly my issue is depression. Many of our patients, as you know, are very depressed just by the disease itself.
Absolutely. Depression is more common in MS than in other diseases, including Lou Gehrig's or ALS. And it just came out in Neurology Today this morning regarding physician-assisted death in MS. And it was surprising how many people with MS would accept that. And one of the lead authors was suggesting that was because of undertreatment of depression. And I really think that that's kind of a big issue. And I think the perception is, well, you have MS, you should be depressed. But I think we need to shift that to, you have MS, it can be frustrating, you may have depression, but we should treat that and help you be as much as you can be despite this disease.
Isn't that interesting that the data for that article, which originally came out in the Green Journal Neurology about a month ago, came from our NARCOMS registry, and you as a member of the board of the CMSC, we hear all about the registry, which is a registered population of people with MS, and all this now is coming out, you know, things that people just never believed, that depression was part of the disease and should be treated. So I'm kind of excited about the fact that we're learning so much from the registry. I'm not so excited about the findings, but now we can do something about it.
I would agree. Now we can do something about it. I think too often these were issues that weren't talked about. The other issue is cognitive impairment. I still hear people say there's no cognitive impairment in MS.
Yeah, right. You love that one. Yeah.
And I really wonder who they met with MS.
That's right.
Because it doesn't take very many days in clinic to see a fair amount of cognitive dysfunction. And I think
Which is now treatable.
Which is now treatable,
Exactly.
absolutely.
Yeah.
And I think that sometimes the first step in fixing a problem is understanding there is a problem.
That's exactly right, yeah.
And I think right now there's not enough emphasis on managing the symptoms. And I think because of that, many people go for complementary medicine, many people go to the internet, many people are looking for answers that they're not getting with their neurologist or with their MS team.
Right.
And I think sometimes that leads to worse outcomes.
Oh, totally, totally. And I think that's the other challenge that we face is the time. I mean, you evidently take the time, but I know that there are many practices, and I've heard it over and over again with the whole healthcare economy the way it is, that they have 15 minutes to see a patient and then they have to move on. And the average MS patient takes a good half hour for a follow-up visit. You know, possibly a headache patient or someone with seizure disorder can come in and out just to check levels and how you're doing and move on. But MS needs time. And that's, I think, one of our biggest challenges with these myths, don't you?
I completely agree that there isn't an exploration because of time.
Right.
And people with MS can have so many different symptoms, and they may assume that a lot of their issues are because of MS, or they may have been told that.
Yeah, tell me the story that you just mentioned before about the orthopedic situation.
So I had a patient that came to see me recently who had a fall in Walmart on a snowy day, and he hurt his shoulder. And he saw me, and he's still having issues with his shoulder, and he found it was hard to do this. So I said, I think it's reasonable to see an orthopedic specialist, whom he saw yesterday. And he contacted me last night, and he was told that it wasn't his shoulder, it was his MS. Which certainly I find challenging to believe because it started when he hit the floor at Walmart.
Yeah, yeah. Yeah, it's been a rough winter. Yeah, it is. It is. It's very challenging, and it's very hard for you professionally to contradict the orthopedist. So I would wonder how you would handle it very professionally.
I think it's always hard to know where a symptom comes from.
Sure.
And I think one of the things that we assume is what somebody else is feeling.
Right.
And I think for as broad as our language is, we can never really know how somebody else is feeling. And how their symptoms and how their disease may impact them as individuals. Yeah. And I think that there's a lot of misperceptions that come in clinic. We talk about people with a high pain tolerance and a low pain tolerance, but how do we really know? How do we
That's right.
define that in an
Exactly.
individual?
Yeah, you take the scale and those happy faces, 0 to 10, but you're right, what me is painful may not be painful for you. I mean, it's very hard to use that scale and be able to climb into your shoes and to feel what you're feeling. And it's so much easier to give a person an opioid, rather than explore. Speaking of that, do you find opioids helpful in pain management?
I really don't. And I think that there's really 3 kinds of pain in MS. I think there's primary MS pain, which is usually disordered sensation from damage to the nerves, can be numbness, tingling, burning. I actually think of them as short-circuiting of nerves.
Right.
And I find that anti-seizure medicines often help well for that, because I think of seizures as short-circuiting of the nervous system as well.
Yeah.
Secondary MS pain, premature wear and tear because of alterations in gait. I find those can be more responsive to anti-inflammatories. And then tertiary MS pain, which I think is very common, is the psychological impact to how people feel about the symptoms
Sure.
that they have.
Or how they look.
Or how they look.
Some people get very upset when they look in the mirror and they see that they're not the way they still picture themselves as a young person.
Absolutely.
Yeah.
But I also find that people get really frustrated when people say they look so good, but they feel so bad.
I know.
And sometimes many of the symptoms of MS, the depression, the cognitive dysfunction, the pain, may not be visible to an outsider, somebody looking in.
Right.
And sometimes I think there's wondering, why is this person not doing as much? Why is they not as engaged? Why are they retreating? And I think it's hard for people with MS to find somebody that understands.
The other person in the duo is sometimes the spouse or the partner. I remember I had a very, very good friend with MS, and she had a husband who was very devoted, but he would escape sometimes. You would just go away for days. And I used to get angry because I was like siding her with her. And one day I sat down and thought about it, and I talk about the pain of a spouse or a partner seeing what's happening to their partner and not being able to do anything about it in terms of the disease, particularly in those years when we didn't have DMTs. And we can't forget about the partner, the person that's affected. And the one that I really worry about more than a partner is the children. We don't do enough to help the kids cope with a parent's illness when they're young, even when they're older.
I completely agree. I worry a lot about the support partners, about the spouses. This disease can really affect relationships.
Sure.
And being a disease of young people, it can be hard for the partner or spouse to deal with.
Right.
And certainly young children, I think it must be very hard for them to understand what is going on with their mother or father. And I think it must be hard for them not to become frustrated. Why doesn't mommy or daddy do whatever they used to do?
Right.
And I suspect that may be really challenging. It may affect their identity, their performance in school, and it's certainly a huge problem that also needs to be addressed, as well as all the other symptoms that we talk about in clinic.
Yeah, absolutely. That's why you need support people for you even and within a clinic. If you see that problem, there's got to be resources, and sometimes they're just not. That's probably one of the challenges that we face, trying to address the whole family.
I really believe that MS care should be multidisciplinary, or especially interdisciplinary,
Right.
Where there's easy access to rehabilitative specialists, psychologists, social workers, nurses, the whole gamut of care. And I think especially in this day and age, people almost need an economist or an advocate to help them access the care that they need, given the current status of the medical economic world.
Right, and then one last thing I wanted to talk to you about. Over the years, we've always said that MS didn't affect lifespan survival. And, you know, life planning is not something you normally would do at age 22, but how do you find, you know, how do you advise a person with MS in terms of managing their finances? Or, you know, here they're faced with huge bills with disease-modifying therapies, partially covered by insurance. What do you do if a person's having trouble paying for these things and managing a family and paying a mortgage and trying to get a car? I mean, how do you deal with that?
That can be very challenging because it's certainly not what my training is in. I think the involvement of social workers, the awareness of all the support that's available. And I also talk a lot about retirement as an analogy for the disease-modifying therapy. I say what we're trying to do is we're trying to save brain for tomorrow, and that kind of leads into saving money for retirement for tomorrow. And I think people often get that. And I think it's challenging because in MS you want to be very hopeful. You hope that the individual you're seeing is going to do very well, but you also want to be authentic, and you don't want to mislead or even lie to the person, obviously. So it can be a really fine balance between authenticity and being genuine and being honest and being hopeful. And it's, I always worry what the fine line is, and it may vary from person to person.
Right, realistic hope is very hard to define, you know, because like you said, each person gets it differently, and the line may move with each person. And so it's a challenge, it's an ongoing challenge. And again, you don't want to have this false hope pasted on your face. On the other hand, realistic hope is a good way to look at it.
Realistic hope is a good way to look at it, and I think in making sure that people are engaged in managing their disease. They need to be an equal partner. They need to be at the table helping make decisions, explaining what is going on. And I really think that people need to ensure that they continue to do what they can do and not focus on what they can't do. And they need to be an individual that just happens to have MS and not an MS patient. Those subtle changes can really affect outlook and can really improve outcomes.
Well, I bet if somebody could just clone you and send you all over the country, it would answer a lot of people's prayers.
I've heard that rumor, you know, and I think one of the...
By cloning you? That's interesting.
No, but I think one of the things that I would like to do is how do you change care, not in my clinic with the people that I see, but how do you change care in the nation? How do you change the system so that people have the time to provide the quality of care that I think people with MS deserve? And I actually think that in the long run, that will save resources. I'm a believer that doubling the time that a clinician can spend with their patient may actually reduce cost, because it's a lot easier but more expensive to say yes, and it's probably a lot more cost effective and more appropriate to explain why no.